Hey, welcome back, everybody. Time once again for some Living Hope. The one show, maybe the only show, shows you the real life struggles and success and courage it takes to be on this journey we call Living Hope. For those with pancreatic cancer, like our host, our host, Roberta Luna, welcome back.
Thank you, Paul. Feels like forever since I've been here, but it's nice to be back. It's been a tough month, but anyway.
Been a tough month. You've been to lots of meetings and other places and stuff here, so.
Yeah, it's kind of hard. People have told me I need to clone myself, but I'm telling them you definitely don't want two of me. One is fine. So.
Okay. All right. Today is a continuation of an earlier conversation we had about diabetes and pancreatic cancer. I didn't know there was such a thing until you guys opened my eyes last time here.
Yeah, there is a link between diabetes and pancreatic cancer, and we have Dr. Shariff, an endocrinologist, associate professor at Duke University, and co-founder of Citrus Oncology. Also, we have Cindy Gavin, CEO and co-founder of Let's Win Pancreatic Cancer. Happy to have both of you back, and I love speaking with you, and I'm sorry, I know I always mess up pronouncing something, but I don't know. It's the way it is, I guess. It's not much I can...
We expect it now, Roberta.
I try, but it doesn't always work well.
Well, Roberta, thank you for having us back on the podcast, and certainly excited to discuss about this topic that really deserves a limelight. And you're not the only one who thinks I'm an oncologist. Whenever I give talks, I always go there. I'm like, first disclaimer, I am not an oncologist. I'm an endocrinologist, but I live in the world of oncology. Because there are very few of us who do this. So it's always that disclaimer. So you're not the only one. Everyone asks me this question.
Now let's get Dr. Shariff to back up a little bit, because you're moving and I can only see half of your face there because everybody's got you on there,
okay.
Like that. That's better. Okay.
So maybe you could actually explain what it is that you do, what you do. And like I said, I'm looking right at it. So it's not, I don't know why I called you oncologist. I'm looking at what you do. But explain to us what you do and what your role is with an oncologist or with pancreatic cancer.
Of course. So I practice what we call oncoendocrinology, which is endocrine disease in cancer patients, which is slightly different than just practicing general endocrinology. Now, when you think of endocrinology or endocrinologists, they're managing routine diabetes, thyroid disease, they're managing problems with the hormones, testosterone, adrenal deficiency. But when you look at an oncoendocrinologist, which is a field that is new within endocrinology, perhaps a decade old, which is when I kind of started doing it and people around the country started realizing that there is a need for oncologists to work very closely with endocrinologists, and that there has to be a subset of endocrinologists that really keep up with the changing landscape of oncology care, because there's so much happening in the oncology space that it is another field to keep up with. And this is why we identify ourselves as oncoendocrinologists, and we manage anything and everything in a cancer patient. So all hormone disorders, diabetes, adrenal insufficiency, anything that comes about as a side effect or as a consequence of their cancer or their treatments is managed by endocrinology. And that's what the field of oncoendocrinology is all about.
So why is it so helpful then to include, you would be like a hormone specialist? Would that be a way of putting it in simpler terms, maybe?
Yeah, you can call it a hormone specialist that manages hormone problems in a cancer patient.
And then in the care team for someone with both pancreatic cancer and diabetes, what role would you play in that?
So as far as pancreatic cancer, and we've kind of touched over the subject of the last recording as well, is that pancreas makes insulin, which is one of the important hormones, right? When you call it a hormone doctor, insulin is a hormone that is made by the pancreas. And when you have cancer within the pancreas, or radiation treatment or surgery as a consequence of their pancreatic cancer, you're going to unmask diabetes, because now the pancreas is unable to make insulin, which is an essential hormone that comes out of the pancreas to maintain your blood sugars. So this is why we see that about 40% individuals who walk into a diagnosis of pancreatic cancer either have prediabetes or diabetes, and an additional about 40 to 45% of them develop diabetes during their course of their disease. So if you put all those numbers together, roughly about 60 to 85% individuals with pancreatic cancer are going to experience some or the other form of either prediabetes or diabetes before, during, or after their cancer treatment. This is why it's so essential and it's so important to raise awareness around the need for a oncoendocrinologist or an endocrinologist as part of that team. There's surgical oncology, there's medical oncology that manages pancreatic cancer, and the consequences are managed by the oncoendocrinologist, especially the one that is diabetes.
So when would you come in? Is that something that the patient would ask for or the doctor would bring in, or how, I mean, I never even knew this until, we talked about it. So I don't think I had that benefit, but how does a patient find out, or how does it happen?
So it's often not coming from patients unless it's that one percentile club that's really looking after their blood sugar and saying something's really wrong with me. And keeping a tab on, okay, I had my blood sugars were X, my A1C was X, now it's going up, right? So that's a very small percentage of patients that actually come up and ask that something needs to be done about my blood sugars. A majority of times, these are decisions that are made by the surgical oncologist who is working on the pancreas, planning to remove part of it, and they see that the patient's blood sugar is high, and it's not a right time to take the patient for surgery because their blood sugars are so high. So the referrals can come from a surgical oncologist or from a medical oncologist, because now this same pancreatic cancer patient is receiving chemotherapy, and chemotherapy comes oftentimes with steroids like dexamethasone, and patients receive those steroids as part of their treatment every 2 weeks, and steroids increase blood sugars. And that's why you need more insulin to match those blood sugars. So the referrals can come from medical oncology, the medical oncologist of the patient, or the surgical oncologist. But oftentimes, unless patients are advocating for themselves or know about this, or have heard like a podcast like what we're recording right now, that this is an important problem and they need to have their teams look at it, it's oftentimes not the front and center part of the decision making when a pancreatic cancer patient is taken care of.
Are you able to help manage symptoms such as like fatigue, appetite loss, or weight changes with pancreatic cancer patients?
If they're coming from diabetes, absolutely, right? Because the symptoms that you just mentioned are the same kind of symptoms that you would get with pancreatic cancer, and also are the same symptoms that you would get with poorly controlled diabetes. You get weight loss, you're eating a lot, which is different from what you just mentioned. The appetite's not low, it's actually higher or maybe lower, but they lose weight and their sugars are high, and they're very symptomatic because they're peeing out a lot of sugar in their urine, so they're almost always fatigued. So that if it is coming from high blood sugars in the context of someone having a blood sugar of say 350 or 275, when we control the blood sugars, those symptoms do get better if they're coming from the diabetes only, right? Some of this could be coming from the cancer itself, but what I tell my patients is that half my job is to tell you what it is and half my job is to tell you what it's not. If it's coming from your diabetes and it's coming from high blood sugars, after I fix it, if you get a resolution, I know that it's coming from your diabetes and it's something I can fix. But after your blood sugars are well controlled, if you're still having fatigue, it's probably coming from a lot of other variables, right? You got cancer, you're not able to eat, you're probably having diarrhea from the cancer itself. And either you're anxious about your diagnosis, you're not sleeping really well. You're not eating, you're not enjoying life like you did. There's a lot of variables that fatigue can be explained with, right? I say fatigue is $1 million diagnosis in medicine. You go to a neurologist, to a podiatrist, everyone has a different way in which they look at fatigue. In my world of endocrinology, I look at fatigue coming from their cancer treatments, coming from steroids or the lack of steroids. I look at it as coming from high blood sugars. And those are all things that we can treat.
I had somebody asked a question, and I hope it's not too much, but they wanted to know if their urine has a really sweet smell. Could that be something telling them that maybe they should check and look into diabetes, or is that something different?
Yeah, no, absolutely. So the word diabetes mellitus is sweet urine.
Oh.
That's the way the name is that's what, because before people didn't know how to measure blood sugar, so the urine tasted so I don't know who tasted the urine, but there's two different diseases. There's diabetes insipidus and diabetes mellitus. Mellitus is sweet. I think it's in Latin if I'm not wrong, but mellitus means sweet, and insipidus means plain urine, so it's a completely different disease. In insipidus, you are peeing out dilute urine, which is why it's tasteless. And then in mellitus, you're urinating excess sugar, which is why I was saying, right? One of the link to fatigue is that you are not able to keep the sugar in your body and you pee it out in the absence of insulin. And that's why your sugar is coming out through your urine and you're so tired. So that is the exact definition of what diabetes mellitus is.
Oh man, that was interesting. I've never heard that before, and I'm not sure I want that taster job either. But
yeah, that's why I was like, I'm not sure who did it many eons ago, or centuries or decades ago, but that's how they figured out what was wrong with people.
yeah, that's interesting because she just mentioned that her urine smell. Somebody mentioned, it's just really strong, very sweet to smell, and
Yep.
she was just curious, should she be checked for diabetes, and she
I
is
absolutely
dealing
think
with
she should.
pancreatic cancer, so
I absolutely think she should be tested for diabetes. And I think it's important not just to get the A1C, it's also important to wear a continuous glucose monitor. And I think we may have touched on this in the past about A1Cs having a good way of interpreting it. They're both useful, but it's important in which context you're looking at the patient, right? A1Cs are good about a bird's eye view and saying that this patient needs to come in front of the line, and this patient has poor diabetes or well-controlled diabetes, no diabetes, or diabetes. It still doesn't tell me what really happens with the patient on a day-to-day basis, which is where continuous glucose monitors are helpful, right? So if you think of the difference between the two, A1C is like reading the preface of the book, all right? And when you check a random blood sugar, which is finger stick blood sugar that most oftentimes primary care physicians are usually employing, they give patients a glucometer and say, hey, check your blood sugars. When you're checking glucometer-based blood sugars, it's like you open the book and you read a page and you're trying to make sense of the page, which is what you're doing with the blood sugar randomly in the day or in fasting. It doesn't tell you the whole story. When you look at continuous glucose monitors, it's like you're reading a book from cover to cover. It tells you the story. It tells you what's happening with the blood sugars before, during, after you eating, what happens overnight. So it's a full story. All of these are helpful depending on how you want to interpret the data and how you want to use this. So I think I want to make that distinction that one is not better than the other, but they're all very helpful in answering different parts of the piece of the puzzle.
Okay, thank you. And I know like we did talk a lot about this the last time, and I don't want to spend a lot of time because I really want you to tell us about your citrus oncology. So unless there's something else you want to throw in there before we go to that subject, then I'd really like to learn more about you, about what you've been doing. And you're the co-founder, so can you?
Absolutely. I think, coming from the experience, I've been doing oncoendocrinology for over a decade now, and really have seen, and I work in an academic institution, which I call the ivory towers of medicine, right? Where there's great expertise, but poor access, right? Every patient does not live near the Dukes and the MD Andersons and the Sloan Ketterings. They live somewhere else, and they're getting treatment somewhere else for their pancreatic cancer or other things, right? The idea was that we connect patients and oncology practices where a majority of cancer patients are getting their treatment to specialists, and get them connected really quickly. And that was the idea behind Citrus Oncology. How do we connect access to specialists and try to scale their time in order to make a system that works for everyone, that supports oncologists in a timely fashion and supports patients in a timely fashion and connects the dots? Because right now, what happens is that if you want to see an endocrinologist, currently there was a Good RX report that came out last year that said that 70% US counties lack an endocrinologist. And that's a big number, right? And this is urban and rural. It is not appropriate, it's not subject to where people are living, but 70% US counties don't have an endocrinologist. And people, and the counties that don't have an endocrinologist, the chance of dying from a hyperglycemia related event is 12% higher. That's a huge number. And this is coming from a reputed organization that is looking into these details, right? So just think about it. We have pancreatic cancer patients around the world, around the country, who need an endocrinologist based on the numbers that I just told you, right? 40% walking in, 40 to 60% additionally develop diabetes as a result of their pancreatic cancer or its treatments. And if you have 70% US counties not having an endocrinologist, how do you manage that? This was really the beginnings and the foundation of why we built Citrus Oncology. Giving that access, connecting patients to endocrinologists remotely. We do everything virtually, so nothing is brick and mortar, which allows a lot of convenience for patients to get this scheduled. And the other thing is, in endocrinology, we, especially in the diabetes world, we're all data driven. We got numbers. We can make a lot of decisions based on numbers. And that's the beauty of working as an endocrinologist, is we talk to the patient, we figure out what's going on, we have numbers, and we can deliver a lot of our care virtually. And it doesn't make a difference if someone comes into clinic, drives 2 hours to see us. So that's what we do at Citrus, is a virtual multi-specialty practice. And we not only do endocrinology, we do cardiology, we do rheumatology, nephrology. Like, think about it as a team approach to managing side effects and comorbidities in patients, and we're here to support oncology practices.
And how do people find out about you, or how do they know who to contact? Do they go through their doctor, or they reach you directly, or how does that work?
So they can go both ways. There are certain practices that we're partnering with around the country, and we are running our pilots. We're running partnerships with some large organizations right now. So patients who are part of those organizations are directly connected with us through the practice itself. The other way in which patients can connect with us is through our website, citrusoncology.com. And we have practices in certain locations right now, even though we have physicians. We have endocrinologists in about 25 plus states that are enrolled on our platform, and we're rapidly expanding that number across the country, but we may not have an active practice in the state that the patient is. So while we're expanding, we want patients to reach out to us, and if we are active in that state, we'd be happy to see them.
What would somebody need to know if they reach out to you? Is there certain information they need to provide to you, or what is it that they would need to do?
Yeah, so when they go on the website and they request an appointment, they get contacted by our intake specialist, who basically gets information about their insurance, about where they live, what the geographic location is, which specialty they need to see. Because remember, we just don't only do endocrinology; we do other specialties as well. And then if we're active in that state, then we go ahead and get that patient scheduled for a virtual appointment with our onco-endocrinologist.
It sounds, do they need to provide like their records to you, or is that something they
Yeah,
would?
so we ask the patients to upload their records through a secure system. They can pull in the PDF. If it comes directly from their oncology team, the oncology team is expected to put in the records so that our physicians on our end can review that case and give the appropriate recommendations. But patients have the ability to upload images, upload PDF documents, and now everyone's EMR is on their fingertips. They log in, they can download their health records, and they can transfer it wherever they want, which really eases up the process of information transfer and the delays that are needed between information transfer. And in addition, if it's a diabetes case, what we usually ask the patients to provide us information regarding their blood sugar data, and we provide them with a chart where they can fill it out so that our physicians, when they see the patient, they actually have data. Because remember, I was telling you that endocrinology is very data driven. If I have numbers in front of me, I can make a very objective decision on insulin, no insulin, how do I treat this patient, what's going on. It's like reading the book from cover to cover rather than opening a page and trying to make sense of it at the visit. So we provide this information to patients so they can fill that out as well.
And this is all done virtually, so they don't have to walk in. So somebody from, say, New York, maybe will be seeing somebody maybe in another state or another area?
Yeah, so we have physicians, but the physicians are licensed in the states that the patients are in. So if it's a patient in New York, we'll be seen by a physician who's licensed in New York. If the patients, right now we are active in the state of Florida, and we are working on getting our licensing in Texas, in Ohio, in the state of Virginia, and South Carolina, and North Carolina. So these are the next things that are going to come up in the next few months. But in the state of Florida, we can bill insurance directly.
But if they're not in their state, then what would happen, or what could you do for them then?
So if we're not active in their state, then we recommend that we would try to find somebody who we would recommend that they see, because we do have physicians in different practices in different states, as I mentioned, right? So if we can get a patient connected directly into their practice, we would approach it that way in the meanwhile, while we're expanding, because we just launched October 2024. So we're pretty new, and it takes time to launch in every single state because we do have state licensing requirements and credentialing. So there's always a lag time between that. So even though we'd love to just open up our doors throughout the 50 states tomorrow, there are logistic limitations to why we can't achieve that. And those logistic limitations are not mine. They're set by the credentialing companies and state licensing agencies and stuff like that. So we hope we can get patients connected to the right physician and provider in that state. But I think Cindy can actually, she has an excellent resource on Let's Win Foundation, and, they already have a geographic footprint of connecting patients to med-onc and surgical oncologists. And that also may be an opportunity where, they can get them connected, or at least be a Rolodex or a place where patients can identify endocrinologists in those states. So I'm just throwing it out there to Cindy to consider for the future, perhaps.
Yeah, thank you, because I was actually going to ask Cindy. So
Yeah.
now that you did that, Cindy, we can ask you.
Yeah, sure. I mean, Let's Win is the go-to resource to raise awareness and help patients get to the best treatment options for pancreatic cancer. And one of our primary focuses is raising awareness of those at higher risk. So it was interesting to me when Let's Win was in its earlier days that even the diabetes community was not as familiar with the link between diabetes and pancreatic cancer. So we have dedicated, now my thinking cap's on about how we could expand this, but we have a whole dedicated section on the link between pancreatic cancer and diabetes. Either someone that's newly diagnosed with new onset diabetes, especially if there's unintentional weight loss, and that could be a precursor to pancreatic cancer. To those that have longer term type 2 diabetes, those that could be at increased risk, especially if they see changes in their condition. And we also have a tool that helps patients think about if they have diabetes. It goes through a series of questions to raise awareness if they're at higher risk. We do have a doctor finder for anyone that is a medically driven doctor finder. So it's based on the number of patients a medical oncologist, a radiation oncologist, or a surgical oncologist sees. So we can talk about linking the medical oncologists throughout the country with the endocrinologists and see, where there could be fruitful partnerships in helping patients identify when they are at higher risk based on their diabetes.
Absolutely. I think that's a fantastic idea. And and I know you all track this data regarding which state has the highest burden of pancreatic cancer, perhaps based on the number of patients that are diagnosed. And I think it'd be worth us talking to figure out, hey, can we get more endocrinologists in that state to manage these kinds of issues and toxicities, right? So I think it allows us to staff according to that as well. Like if Texas is a hotbed or if Florida is a hotbed for this, then for those number of patients, how many endocrinologists do we need? So it's almost helps with the needs assessments as well.
And one of the things I wanted to mention is that in the Latino community, there is a slightly higher risk of diabetes. And Let's Win has Let's Win's program. Everything that Let's Win has published over the nearly 10 years is medically vetted and is available in both English and Spanish. So we have a bilingual program, and everything that we have available in English we have a mirror platform in Spanish. So I think that would be especially helpful for the Latino community.
That's excellent. That's excellent, Cindy.
And I have to agree because I've looked at your one in Spanish, and what I love about it, it's the whole thing, your whole website. You can either do English or Spanish. A lot of others only have certain sections that are in Spanish, and then you have to call or go some other way. I like the fact that you can just go to it, and I've shown it to some Hispanics, and it's very well done. So I really take my hats off, and I've mentioned it before, I think, on podcasts, that you guys have really done an excellent job with that, providing that information. So thank you.
It toggles back and forth, actually, because we know that a younger generation is often helping. The average age of someone that's getting pancreatic cancer is typically closer to 70, but we know that a younger generation is supporting their family members very often. So you can toggle between English and Spanish, which I think is helpful.
It is very helpful. Like I said, I've done both. So like I said, it's a really great website. So thank you for that and for everything that you do. Is there any added words you'd like to leave us with? I think we're about out of time. So if anything you want to leave us with?
I think I'm going to add one more thing, Roberta, here, because this is just really fresh in my email right now. Because remember, we were talking last time regarding the new program at Duke, which is the Duke Pancreatic Cancer Program, which you would think that has to be something that was implemented many, many years ago, but it took a long time for them to get all these resources together to create that program. And when we last spoke, I was talking about a collaboration between oncoendocrinology and the pancreatic cancer program, right? So we've discussed that, and that's actually coming about as a strong collaboration between all three of us, which is surgical oncology, medical oncology, and oncoendocrinology, with triggers to when to consult endocrinologists within the Duke system. But what I want to leave you all with is that, number one, such programs are needed everywhere. I think such collaborative, multidisciplinary approach is so important in the overall well-being, response to treatment, survivorship, the patient journey in general, right? Like how they respond to treatment and how they take that journey, especially in pancreatic cancer, because it is such a debilitating diagnosis to begin with. And plus you have another big disease that is attacking them at the same time, which is diabetes, right? So I think it's important to have such cohesive and collaborative approaches around the country, number one. The other thing that we have co-developed is nutritional information, which is just my nutritionist just sent it over to me. She's our diabetes educator, and I asked her to develop a nutritional guidance for patients with pancreatic cancer. Because if you think of it, it's very complex. You have someone who doesn't want to eat, right? Because their appetite's really poor. Then they get steroids. So then they're craving sugar, right? And all the carbs when they get the steroids, right? This is part of their pancreatic cancer treatment. Dexamethasone drives that. Their sugars are going up and they're losing weight despite all of the above, right? Sugars are up, they're going to lose weight. They're not eating as much on non-steroid days. They're losing weight. They got pancreatic cancer. They're losing weight. And when you go to general oncology nutrition, they ask them to eat more to gain weight. And I'm on the other side, nuh-uh, that's not how you do it, because if you eat more of the wrong stuff, your sugars are going to go up, you're going to lose weight, you're going to feel more tired, and it's not going to do justice to you. So it has to be a nutritional advice that is tailored for pancreatic cancer patient, fat, protein, and carb ratio, so they're not having diarrhea. They are absorbing their carbs well. They're eating the right kind of carbs. They're not overdoing the carbs to trigger high blood sugars. And 3, the timing of their creon. All of these play into role from a diabetes perspective and a patient well-being perspective, and I don't think there are resources around this. There is not a lot of good guidance around this because they get the same general advice as any cancer patient would. Eat whatever you want, just gain the weight. We want you to eat more because you've lost 60 pounds, we want you to gain weight. But that is bad advice for someone with pancreatic cancer because their sugars are going to go up and they're going to go lose weight because their sugar is poorly controlled. So I just want to underscore that at the end of today's recording, because this is important and often missed.
Yeah, thank you. We're always talking about trying to get them the best nutrition, not go out and eat whatever you want, have a malt or whatever. That's, to me, you're feeding sugar, and if you believe sugar is feeding the cancer, then that makes no sense. I'm sorry, Cindy, I interrupted you.
Yeah, no, I was just going to say we have a dedicated section on diet and nutrition, and I would love to make an appointment to meet with your team so that we could share the great work that they're doing.
Fantastic. I will definitely get our dietitian in touch, because I think it's so important to tailor it with the perspective of diabetes. Now, everyone doesn't have to follow this with pancreatic cancer, but if you have diabetes and pancreatic cancer, the guidance needs to be really tailored to both those diseases.
Yeah. Thank you, ladies, very much. Really appreciate seeing you again, and I hope we covered everything. But if not, we can always come back and do it again. I think it gives a good opportunity, so thank you.
Thank you for
I'm sorry, I think Paul might have a question?
No.
No? Okay, good. I misunderstood that wave. Okay. As long as you speak my name is dedicated to Jill Gish.
Well, there you have it. One more reason to tune in each and every time to Living Hope, a weekly journey designed to provide hope, inspiration, and education for those living with pancreatic cancer, sharing the real-life stories of those really affected and how they deal with it on a daily basis. And if you need information immediately or want to follow up on any of these discussions, as we said, there's a place to do that. Let'sWinPC.org. Let's Win PC for pancreatic cancer. Let'sWinPC.org. For those of us here at the OC Talk Radio Network, we thank you as always for tuning in. Hope you'll share this, and most importantly, come back and share the journey we call Living Hope, as we stream live from our studios here at the University of California, Irvine's Beale Applied Innovation Center.